Good morning and welcome to the American Heart Association's Don't Die of Doubt community event, brought to you by the W. Caruth Jr. Fund at Communities Foundation of Texas. Please welcome your host, Vice President of Health Strategies for the American Heart Association's Dallas Division, Jenny Iyer.
Hi, everyone. Good morning. Thank you so much for joining us today. We are incredibly grateful for your time and look forward to an informative presentation and panel discussion around the current status of COVID-19 in the North Texas community, the steps the medical community has taken to keep all of us safe, and why it is important to remember the hospital is still the safest place to be in an emergency. As an organization whose mission is to be a relentless force for a world of longer, healthier lives, the American Heart Association recognized there was a need for more awareness to be associated with this unique time in history. The Don't Die of Doubt message, which stresses the importance of calling 911 at the first sign or symptoms of a heart attack or stroke, is incredibly important at this moment as we continue to see pandemic-related hospitalizations increase, mirrored by an increase in uncertainty and anxiety in our communities. But we all know that heart attacks and strokes do not stop for COVID-19. We are thrilled to have a group of experts build off of this message and share what each of them has experienced in their respective positions since March. Before I introduce our keynote speaker, I want to mention a few things that I'm sure you're very all accustomed to hearing in all of your meetings since the beginning of this year. But if you have any questions at all, please put them in the chat box. We will have time for questions after both the presentation as well as the panel discussion. Our team will also be monitoring the chat throughout our time today for any additional general questions as well. Now, we are incredibly grateful to have Steve Love join us this morning to share more around the Don't Die of Doubt message and its importance for this time. Steve Love is the president and CEO of the Dallas-Fort Worth Hospital Council, as well as a Southwest Regional Board member for the American Heart Association. Welcome, Steve. We are so happy to have you. The virtual stage is yours.
Thank you very much, Jenny, and thanks to everyone participating, and special thanks to the American Heart Association for sponsoring this. You know, it is a real privilege to speak to many of you today. And for those of you that don't work directly in healthcare, I'm going to kind of go behind the curtain and give you a little backdrop. We all know that COVID-19, as far as we can tell, originated really in December of last year in Wuhan, China. And it really made its way to the United States, as we all know, through Seattle. But our first confirmed case was here on March the 9th, here in North Texas. On March 12th, Dallas County declared a state of emergency. And then we issued via County Judge Clay Jenkins a shelter in place on March 22nd. And then Glenn Whitley in Tarrant County on March 24th. On May 8th, we had over 1,000 people that had already died, unfortunately, from COVID-19 here in North Texas. So where are we really today? Well, today we're in a pretty substantial surge. Yesterday, we had 2,530 hospitalized people in North Texas and Trauma Service Area E that were being treated for COVID-19. That represents about 16.6% of the available bed capacity. And of all the people in ICU, approximately 39% were being treated for COVID-19. As we look at our current indicators and our models, we think that's going to go up a little more this week. And from what the epidemiologists tell me, it's primarily a result of Thanksgiving, where people were out and about, had family gatherings, etc. For those of you that don't deal directly with infectious disease, and I'm certainly not a clinician, but I enjoy talking to the infectious disease doctors, the epidemiologists. You've got to realize COVID-19 is very infectious and it will spread. And they track it using something called an R naught factor. Let me give you an example. Measles has a R naught factor of about 15. What does that mean? That means one person could easily infect 15 other people. Well, COVID-19 does not have a R naught factor as high as measles, but we've been running about 1.8 to 1.9% in Dallas, Tarrant counties, and then some of the other counties here in North Texas recently. You really want that R naught factor to be below 1 if possible. And that means only one person affects or less than one person being affected by another individual. That's how you tamp down that community spread. And wearing masks, physical distancing, washing your hands, staying out of large crowds, to be candid, are the very best tools that we have in the toolbox to deal with COVID-19. If you wear those masks, and everyone does, then not only will you help prevent the spread, the infectious disease doctors tell me the viral load will not be near as great. And they actually have done tests on guinea pigs where the guinea pigs, with the cages they were in being covered with material similar to what's in a mask, didn't get as sick, even though they did get infected. We're very blessed here in North Texas because all of the first responders, all of the hospitals during an emergency like this take off their competitive hat. We've got 90 hospitals here at the DFW Hospital Council. And of course, in the normal course of business, they compete. They want each other's market share. That's just capitalism. But in an emergency like this, let me just tell you the collaboration, the cooperation, and how they've worked together, not only with each other, but with skilled nursing facilities, long-term care facilities, the first responders, and you're going to hear from MedStar later, I think, on the panel. It has just been phenomenal the way the people come together and cooperate and take off that competitive hat. So what's been happening since May? Well, as you know, we had a summer surge. It primarily hit 4 counties: Dallas County, Tarrant County, Denton County, Collin County. Let me tell you what's different now. We have had a tremendous spread throughout Trauma Service Area E. Grayson County last month had more days of higher hospitalizations than Denton County. Ellis County has had quite a few hospitalizations. My point is, this is reaching into the rural communities, and we're very blessed to have the hospitals that we have in these rural areas. They do an outstanding job, but here's the issue. They don't always have the bed capacity, especially ICU capacity. So many of those outlying counties have to send their patients into the Metroplex. Another thing that we're experiencing now in December that we really didn't experience when this first hit is what I call the remnant impact on capacity related to COVID. And let me explain what I mean. If you go by the federal definition and the state definition, a person that comes into the hospital that's treated for COVID-19 is generally in a COVID unit, obviously is isolated. As Jenny said, it's a very safe place, but those people are treated, but after a period of time, thankfully, we hope they're going to recover, and they're recovered and they're uninfected for COVID, but they still can't go home. Why is that? They may have an underlying cardiovascular problem. They may be diabetic. They may, unfortunately, I talked to a neurologist yesterday. He had a 38-year-old, relatively healthy individual, male, that had COVID-19 and unfortunately had a stroke. And as a result, was now in ICU. We're having people that are impacted by COVID that get out of the infectious state, thankfully, but they still aren't well enough to go home. And that takes up additional bed capacity. So COVID has an impact far beyond, in some cases, when you're infected. Some other things that I think that are important is we've been blessed here in North Texas because we have very effective and well-run hospital systems. And we do have the bed capacity. We now have the PPE. I will tell you, in February and March, in some cases, especially in some of our smaller hospitals, PPE, personal protective equipment, was hard to come by. But our biggest issue now related to this big increase in volume is staff. Stop and think. You're going to hear from some physicians later in this panel. I mean, I salute all the clinical people that have been at this since February. They absolutely, many are working double shifts. Many have not taken time off. Many are doing things that are unbelievable. I actually talked to a hospital CEO last week who went to the COVID unit, and I'm not going to name the hospital, and there was a nurse who had worked a double shift. And as she came off the unit, he said, "How's it going?" She said, "Well, in my double shift, 5 people died. I was holding the hands of 3 of them. And the others, I FaceTime with their families before they passed." And she said, it's taken a toll and emotional strain. And this is one of the toughest times I've ever had in my entire nursing career. And he said, "Is there anything I can do?" And her response was, "Get people to please care enough to wear a mask, physical distance, and stay out of the hospital so we don't have to be here when they pass." And, you know, that's a very emotional, touching experience. But we really do need to get our family, our friends to do prevention, prevention, prevention. The other thing I wanted to talk about is not only do these healthcare workers do such a great job, unfortunately, social media has put out a lot of bad information related to COVID and related to hospitals. And I do want to take the time just to make it real clear. When COVID first hit, the federal government, Republicans and Democrats, passed the CARES Act. They worked collaboratively together. President Trump signed this. It was bipartisan. They did an extra 20% add-on to the COVID DRG because they knew the staffing, they knew the PPE, they knew all of the isolation was going to add cost. And that's what they did. They did it in the spirit of trying to help defer some of those expenses. On social media, you read about hospitals get paid more when patients die from COVID-19. Totally false. Hospitals upcode and code people and say they have COVID when they don't to get more money. Totally false. And then finally, you know, hospitals aren't making big profits from COVID-19. In fact, most hospitals have lost money in the last 6 months. Now, we're here for the community. We're here to support you, and we want to thank you for the support you give us. But some of this information on social media is very misleading and counterproductive. And the final thing I wanted to say before I take questions, if you get an opportunity and you see a healthcare worker and a clinician, thank them for what they've done. They have put in long hours. They take their servant attitude and caring. And it doesn't matter if it's a physician, a nurse, a respiratory therapist, the infectious disease folks that come in and do the cleaning and the sanitation work. It's really been a team effort. But the other thing that we really want to stress, and this panel is going to deal with, yes, we're there to treat COVID, but we're also there to treat non-COVID. Don't be afraid to call 911. Please make sure that you see your cardiologist. I'll give you a great example. I'm going to see a physician this afternoon for a routine checkup related to a surgery that I had a couple of years ago. don't put off non-COVID treatment. It's so important that we continue to improve the health of the community. I'm going to stop there. I do have a few more comments I can make, but questions are the most fun for me, and I really enjoy it. But on behalf of all of you that tuned in to support the American Hospital Association, in my role on the Southwest Board, let me just say thank you. We cover more than the state of Texas, and it's people like you through your support that really make the mission and the achievements of the American Heart Association really come to fruition. So, Jenny, do you have any questions?
Thank you, Steve. I do. I want to ask, as we are, moving away, from the very beginning where there were so many questions, and not a lot of just a lot of questions, not as much information, as we're learning so much more. I think there are still questions about the long-term impact of COVID-19, and I know that our panelists will be getting this question as well, but wanted to touch base with you on it. Not only in the medical community, but maybe in the general public as well.
Yeah, here at the Hospital Council, we actually have a radio show we do every week called The Human Side of Healthcare. And I've been very, very fortunate to secure some really prominent local physicians. This is what I'm hearing. On some of the real long-term effects, it's still a lot to be determined. But they do know this: there are some cases where they have long haulers, especially related to people who have underlying conditions like cardiovascular, and unfortunately they've had a stroke, that have diabetes, that are obese, and they're still studying that impact. On the flip side of that, some positives, the physicians, to their credit, have learned a lot about treating using remdesivir, steroids, and we're doing a lot of things that we learned. For example, we learned from New York, you don't have to vent every patient. And that's why we have not had a big shortage of ventilators that on the outset we thought we would have. The other thing, Jenny, and I'd be remiss, we're very excited. There is light at the end of the tunnel. I think most people know we could have the Pfizer vaccine here in Texas next week. Moderna will probably be about 10 days behind them. Believe it or not, AstraZeneca is working they're in their phase 3 with University of Oxford, and they'd have to get approval. That's down the road, and even Janssen. So help is on the way. Vaccines are on the way. But here's my message to caution people. They're going to be disseminated to healthcare workers, first responders, and they have what they call a category 1A. There's a tier 1 and tier 2. I talked to DSHS yesterday. We're hopeful Texas will get 1.6 million doses by the end of the year. What does that mean? Well, we've got about 1.6 million hospital workers and first responders, and that doesn't include the elderly and people that are in senior living. So it's probably going to be by the end of January before we get all the healthcare workers optimistically done. For the general public, please be thankful for the vaccine, but don't let your guard down. You probably are going to be wearing masks for another 6 to 9 months, but that's a small price to pay to know that at the end of that period, we're going to get a vaccination. So please don't let your guard down. But long-term effects, Jen, we're going to learn a lot, I think, as we go forward. As I talked to a neurologist, there's a lot of impact on the brain and on some of the neurological that we still have got to learn. Could be long-term effects of COVID-19 and mental health as well. There are a lot of mental health, behavioral health issues associated, depression, etc.
Yeah, absolutely. I feel like we're going to be learning about this and seeing its impact for quite some time. You mentioned something about learnings from New York, and I know that a lot of people, at least, that aren't in that, you said you were pulling the curtain pulling us behind the curtain in the medical community, but some of the camaraderie and the collaboration is very new. And as to your point, we're learning from people in New York and learning from across the globe. Could you speak a little bit to what that has done and to be able to really help us learn so much more quickly than we normally do?
Yeah, here at the Hospital Council, we've been fortunate. We convene the CEOs, of course, but we've convened the chief medical officers from all the major hospitals and hospital systems, chief nursing officers. I could go all down the line, human resource people on workforce issues. And I've learned from the chief medical officer group the following, and you're going to have some physicians on the panel that are much better equipped to answer this than me. But I was just impressed as I listened to the chief medical officers of some of our large systems as we got into March and April, and they were learning from New York. They were actually talking to colleagues in other states. They were talking to emergency room people in other states. In fact, some of the physicians were even talking to some of their colleagues in Europe who had really treated this, because I learned as I listened to them, there was kind of a strain of COVID-19 that came through Italy, and it kind of came to New York. What came to Seattle was more from China. It's still all COVID-19, don't get me wrong, but it was kind of like it was making changes and modifying, and I won't use the word mutation, but there were different forms of this. And I was so impressed. And then I was impressed how our local physicians, whether it be from UT Southwestern, Texas Health Resource, Baylor Scott and White, Methodist, Medical City, I could go on and on, Parkland, they were sharing and discussing. And I was listening because I'm not a clinician, but I was fascinated. They were talking about some of the steroids they were using. They were talking about, have you tried this? We found good outcomes with this. I mean, fairness to these physicians, they really had to fly the airplane and do their flight plan at the same time. We knew nothing about this COVID-19. They were quick learners. They're still learning. There's still more. In fact, I talked to a physician the other day and said, I'm much more comfortable treating a COVID patient today than I was in early March, because we've learned so much and we're still learning. So yes, the sharing of information, the clinical efficacy of some of the medications and products, it's been fascinating for me. And I have been so impressed with the quality of the healthcare clinical delivery by all of our hospitals and physicians here in North Texas.
That's amazing. And it is so wonderful that we have so many just fantastic systems right here in our areas, and I know all across North Texas. And we've got people on our call today from all four of our biggest counties and even past there. So it's just wonderful to know and to hear you speak so highly of all that has been done to keep all of us safe. So one last question, and I know you have making sure that we're wearing our masks and staying socially distanced, but for anything in addition, we had Thanksgiving. We know that additional holidays that are very big family gatherings. In the new year, so many things are around the corner. Any other message you would share with all of our people today and attendees, just to keep in mind, and as we're gearing up and recognizing this is a holiday season unlike any other before?
Yeah, absolutely. In fact, I think a question popped up just a minute ago about the type of mask. And I'm gonna paraphrase Dr. Robert Haley, who most of you know is an infectious disease physician. He worked at the CDC. He was on our radio program, and he actually told us about an experiment. It was kind of funny the way he described it. He said, my colleagues at Duke, and he said, I can't believe I didn't think of this. I can't believe those guys at Duke aren't that smart, but he was kidding, of course. At Duke, they actually took a black box and they put a hole in it. And then they put a special light, ultraviolet light at the back, and they put a camera that could look at, it was a high-speed type camera. And they had an individual cough into the black box, and they watched the air particles, and they could see in film how they spread. Then they took a N95 mask, and the person put on the N95 mask, and then and for those of you that don't know what an N95 mask is, it's kind of a surgical mask. It's kind of the gold standard for using to help prevent. And it was almost no particles when you used an N95 mask. So then they used like a just regular mask that was like 2 to 3 ply that would be a disposable mask, and about 80% of the particles were blocked. Then they used just a piece of cloth, where they put a cloth and they coughed into this box, and it was like less than, it was like 50% were blocked. Well, the point of all this is wear some kind of facial covering and cover your nose and cover your mouth. It will help. And that's where Dr. Haley was talking about the viral load, said even if someone coughed or sneezed, the viral load in the exposure you got, even if they only had one cloth, one ply on, it would help prevent you getting the full load. So I think that's important. We got to keep wearing masks. Try to wear the mask appropriately where you cover your nose and face. I don't know about you, when I go to the grocery store, I see all these people and the mask is below their nose. They may cover their mouth, etc., but you want to wear the mask appropriately. The other thing you do want to do is continue to wash your hands. The more you wash your hands, use hand sanitizer, wear your mask, all the infectious disease doctors tell me that is the very best thing you can do to help prevent the spread. The other thing, I know the holidays are coming up. I know that we finished and we're getting into the holiday season. You know, there is light at the end of the tunnel. We're going to have to make a 6-month short-term sacrifice for the good of the long term. I would strongly recommend people limit their family gatherings at Christmas. And if you do have a family gathering, even if it's members of your family that you haven't seen in 6 or 8 months that come from out of town, you should wear a mask even in the house. And if the weather's warm enough, which it may not be, eat outdoors and spread out as much as you can. These are the kind of things we have got to be vigilant for the next 6 months.
Thank you, Steve. I truly appreciate you being here with us. I'm going to ask, we had one last question come through the chat. I'll ask it to you, and then I know if you had anything else additional that you wanted to touch on as well, please feel free to do so. But the last question is really about the coughing and sneezing without a mask. If we're passing by people, I know to your point, I was in a store and many people had that mask pulled all the way down. I tried to avoid walking near them, but could you speak to how long the virus or the germs associated with that linger in the air? Is that something, and how we can be conscious of that as we might be around people that might not be wearing their mask appropriately?
When I talk to the infectious disease doctors, and I always preface that because I am not a clinician and I don't want to mislead people, but they tell me that, if someone really sneezes or someone is singing like a choir, they could project as much as 9 to 10 feet. So generally speaking, it's 6 feet or less in a normal sneeze or a normal cough. And they said, if you are in a grocery store, you're somewhere where someone coughs and they don't have a mask, pivot and try to move away as quickly as possible to limit the exposure. And they tell me, if you're in a situation where you're talking to someone that doesn't have a mask and you're with them like 5 minutes or less, that's much better than being at a bar or a restaurant where you're there for 30, 45 minutes to an hour, and then you really are getting exposed if someone is infected. So that's the best answer I can give you, but I'm, again, paraphrasing the infectious disease doctors that I've dealt with.
Well, I appreciate it so much. And again, so very grateful for your message this morning and all the work you have done in our community throughout this pandemic. We're very, very grateful for your time. And I know that as questions come in, if we have others that are not answered, we will make sure that we reach out to Steve and get those responses for you as well. Thank you, Steve, again for your time.
Yeah, thank you. And one of my pet peeves, I'd be remiss if I didn't say it. I know we're focused on COVID, and I know you're going to focus on 911. We've got the upcoming legislative session. Folks, we got to do something about vaping. Vaping is not good. I've actually talked to some of the pediatricians and some of the infectious disease docs at our children's hospitals that have treated, unfortunately, kids with COVID, and we do have kids with COVID, but not as many are hospitalized. More adults are hospitalized. But if somebody's been vaping for a long period of time, they tend to have much more problems as they recover from COVID-19. So it's another good reason not to vape. Thank you so much.
Absolutely, and I will echo the vaping comment, and that is something that our community impact team is focusing on as well. So we'll have to keep talking about that as later on as well. So thank you again, Steve. We're very grateful, and as our attendees today really take what Steve just shared with us, I'm gonna let you marinate on that for a little bit. And as we bring up our panel, we are incredibly excited for this wonderful panel and all of the panelists that have joined us today. I am going to pass my digital torch to Dr. Nina Esserani, who's a cardiologist and medical director of echocardiography at Texas Health Harris Methodist Hospital in Fort Worth. She is also an American Heart Association Tarrant County board member. Dr. Nina Esserani, thank you, and the floor is yours.
Good morning, everyone, and thank you for joining us today. I appreciate the kind introduction. My name is Nina Esserani. I'm a cardiologist here in Fort Worth, and my role today is to hopefully kind of guide us through this discussion, talking a little bit about heart disease and then kind of transitioning into the specifics of what we're seeing in terms of heart disease as relates to the health impacts that COVID-19 have also had on our community and on our hospitals. So it's my privilege to be here. And before we get started on that discussion, I'd like to have our panelists also introduce themselves so that everyone knows who is with us today. Dr. Raymond Fowler, if you could just give us a quick introduction.
Well, hello, everybody. I'm Ray Fowler. I'm Chief of the Division of Emergency Medical Services at UT Southwestern, and just so happy to be part of this wonderful session today.
Dr. Jeffrey Schuessler.
Hi, my name is Jeff Schuessler. I'm an interventional cardiologist at Baylor Scott & White at the Heart Hospital downtown. Thanks for letting me attend.
Dr. Cammie Banks.
Hello all, my name is Cammie Banks. I'm a cardiologist with Texas Health Heart and Vascular Specialist. I serve Collin County, and thank you for having me today.
We've already met Steve Love, and then Dr. Denise Hernandez.
Hi everyone, my name is Denise Hernandez, and I currently serve as the president of the Dallas-Fort Worth Community Health Worker Association.
Matt Zabadsky.
Hey, right on time. Matt Zabadsky with MedStar Mobile Healthcare. I work for for two of our other panelists. It's an honor to be here. And I do try and work with Dr. Fowler to make sure that he's more appropriate than he normally is.
Erica Anderson.
Hi everyone, my name is Erica. I am here as a support and definitely involved in the Don't Die of Doubt campaign that I'm very excited for us to talk about later.
And Bethany Lowry.
Hi, my name is Bethany Lowry. I'm a paramedic with MedStar Mobile Healthcare, and thank you for having me.
Did I forget anyone? Perfect. So we'll go ahead and get started. And I just wanted to take one moment to reflect on the American Heart Association. I think sometimes, especially in the world of COVID, we almost wonder, how does all of this fit in? And so I'd like to just remind everyone of the mission of the American Heart Association, which is to be a relentless force for a world of longer, healthier lives. And clearly we're focused on that in terms of its impact on heart disease, but in a pandemic situation such as this, that takes on a much broader context. And so again, I appreciate everyone joining us today in this important work. So before we kind of get into the deep dive of the questions, I kind of want to make sure that everybody's on the same level in terms of their background information. So Dr. Fowler, as an emergency physician, if you could kind of go through the chain of survival for our attendees. So when a person calls 911 and is having an emergency, especially a heart-related emergency, what are the next steps that happen that kind of bring that person to the emergency room, and what are your first thoughts in that process?
You know, it's amazing what a generation will bring. When I started medical school, when Steve Love was still in high school back in the 70s, when someone came in with an acute MI, massive MI, we would put them to bed, give them all the morphine, 100% oxygen. This was pre-aspirin, pre-nitro, and we would pray that they would not die. And about 33% of MIs, myocardial infarctions, would die. Today, myocardial infarction is an acute endovascular emergency, especially a STEMI. So today, what can be expected is that we have marvelous systems like MedStar in Fort Worth, and the Biotel system we're so proud of here, and Liz Fagan's and others, terrific systems, in which we go out, we identify the patient, we do a quick exam, and an electrocardiogram. The medics interpret the cardiogram. It is transmitted to the destination appropriate facility, and a cath lab team will be activated and be standing by. Aspirin, pain control, appropriate amounts of oxygen will be administered, and a direct linear chain of events occurs to be able to open that patient's artery in a very limited space of time. It is amazing, Nina, what a generation has brought.
So that very important first phone call to 911 can now get you some very life-altering medical care. Dr. Banks and Dr. Suchler, as cardiologists, you're very familiar with the signs and symptoms of heart attacks, but it's important that our audience has that awareness as well. So Dr. Banks, perhaps you could speak to the signs and symptoms of a heart attack that individuals should be aware of, and especially the differences between men and women. What are those things that people should be looking out for to know that they should call 911?
The most common symptom that people have when they're having a heart attack is chest pain. And typically that is severe in the middle, the left side of the chest, causes one to feel short of breath, nauseous, may radiate to the jaw or left arm. But many people, including many women, do not have total symptoms. And sometimes the pain will linger in the middle of the chest or move to the back. Sometimes it's not pressure-like and it's more of a burning sensation. So what we would like people to know is that if you have any symptom in the chest, especially if you have cardiovascular risk factors such as diabetes, high blood pressure, high cholesterol, family history, know that that is a symptom that is very important and you should seek medical attention.
Okay, so some very important things there, including kind of the typical chest pain and pressure that we talk about, but even those kind of unusual things into the neck and jaw, shoulder blades, shortness of breath, and very important, as Dr. Banks noted, to be aware of your family history. If that's something that is strong in your family, then of course that could impact your risk as well. Dr. Suchler, perhaps you could speak to why it's so important that you receive care quickly in the setting of those symptoms, and why, with the stress of the holidays and the stress of a pandemic, that this is especially a time of year when we need to be vigilant about this.
So it struck me as Dr. Fowler was talking how far we've come as far as the chain of events that happens after someone recognizes that they're having a heart attack. And the good news is that if we can get to you quickly, From the onset of symptoms to getting the artery open, if we can get to you quickly within 2 hours, usually people end up, number one, surviving, but surviving with very little damage to the heart. It doesn't do a person as much good if 24 hours into their symptoms, we take them to the cath lab and open up their artery. If we can get to them within 30 minutes, they almost always leave the hospital unscathed. So the chain starts with the initial call. The quicker that they get the call started, the quicker we can get you into the cath lab and open up the artery. And we move very fast. So it's amazing. So many moving parts happen in such a compressed period of time. If you call 911, we are actually obligated to, and we try to get you in the lab with the artery open in 90 minutes or less. And we do that pretty routinely. So it's a well-oiled machine, but it's got to start with the first call. So the most important reason to call early is because you can end up with a much better outcome. The stress of the holidays, I mean, the stress of COVID, stress is one of those nebulous things that we know it plays a part in triggering events like heart attacks. It's hard to eliminate stress. I always tell my patients, if you figured out the key to eliminating stress, let me know. It's a near impossibility. But I think that with the holidays, people, they don't want to bother people. They don't want to make a fuss. And so if they start having symptoms that worry them, they don't want to be the person that ruins the holidays by calling the ambulance. I think that the most important thing is everybody would be much more appreciative if you let somebody know if you're feeling poorly versus keeping it to yourself, and the holidays wouldn't be so fun.
Absolutely. Some very good advice there. That adage that time is muscle. And so the sooner you make that call and get into appropriate medical care, the sooner you can have a good outcome, which is so important.
Absolutely.
Dr. Hernandez, as a community health worker, you are a trusted resource and an educator in our communities. Could you talk about some of the concerns and questions that you've seen in terms of reasons that people feel afraid to call 911 or visit the hospital?
Where to begin, right? This is kind of one of those questions that I can go on forever. But we know that with COVID, a lot of our original concerns have just been exacerbated. And so as if there's a single parent with children, if I call the 911, what happens to my children? Can they come? Will they be allowed to come, or are we going to be at risk for getting COVID if we're taken to the hospital? We also know that there's a big fear of cost associated with visiting the hospital, calling for an ambulance. And so with the pandemic, a lot of people have lost their jobs. A lot of people have had to cut back in hours. And so, a lot of people forego care as it is because of cost. And so this is only exacerbated now. And so I think as a community-based organization, it's really important that we learn these concerns and work together to address these concerns. Steve was talking about collaborations. It's right now we're all in the spirit of collaboration. And so how can our community-based organizations work with clinicians to get the message out? What is the message that you as clinicians want us to get out to our communities to overcome this fear of calling 911, or this 2 hour is a key time to get to the hospital, but in that time I may need to find somebody to take care of my children, and I need to find someone to pick them up from school, or whatever the case may be. And so it just again, there's so many things that have been exacerbated with the pandemic that were just already concerns in our community. These are very loaded questions and require a lot more discussion outside of this panel, but it's just something to keep in mind, something for our clinicians and our community-based organizations to really start talking about and working together. I think it's wonderful. It's great that our clinicians are working together. I think a lot of our community-based organizations are also working together to kind of meet those needs and those social determinants to address those. But how can the community-based organizations and clinicians work together to also make sure that we address these common concerns?
Yeah, I mean, clearly, I think there's a lot there in terms of the whole existence of a lot of these organizations like the American Heart Association and the work that you do and many other community organizations, because these are not new issues. But I do think that COVID-19 adds a layer of concern there for a lot of people beyond the already existing financial concerns and family concerns. And it is difficult. I think the hospital policies change on a frequent basis in terms of visitors and all of that. But certainly I can speak to the fact that I think our hospitals are doing the very best that they can to isolate COVID-19 and suspected COVID-19 patients from people who come in with other concerns. So in terms of the concern of getting COVID in the hospital, I think that risk realistically is quite low. And especially very low when measured against the fact that if you're having a serious health related event that you need that medical care.
Right, and that's something that we need to communicate to our communities, and so making sure that we are getting that message out, saying you're going to be safe from COVID, at least if you call 911. And so just, I think it's just that that bridging that gap right there is making sure our communities are well informed of the safety of being in a healthcare facility.
Absolutely. Matt, your teams are often first on the scene, and MedStar has been really diligent in sharing data about what y'all are seeing in terms of the pandemic and how that's affecting individuals calling 911. Can you give us a sense of what you're seeing from when y'all arrive on the scene that's different now than it was pre-pandemic?
Yes, thank you very much for asking. I'm going to let Bethany talk a little bit about what she specifically sees when she goes to these calls. Our fear is doing the data analysis is that we have seen a doubling in some cases of pre-hospital cardiac arrest volume in our system at a time when the response volume generally is lower, the transport rate is lower, and the symptom onset time to accessing 911 in some cases for cardiac cases have been 4 hours compared to the typical 1 hour until somebody calls. So when we do these analyses, we really get concerned that people are waiting too long with heart attack related symptoms that might be leading to obviously further cardiac damage by the time they do go to the hospital, or in some cases even death. We've been told by some of our crew members that oftentimes patients are declining transport to the hospital out of either fear that the hospitals have high incidence of coronavirus admissions, or they're concerned about the capacity issues, or they're concerned about not being able to have visitors. One of our crews shared with me early on in the pandemic during July that they had a STEMI patient who clearly was having a STEMI, and his comment to them was, "I would rather die at home than alone in the hospital." And we as a community and as healthcare experts really need to do what Steve Love and a number of the folks are working really hard at, is to let people know that it's safe and certainly very appropriate that if you're having a medical emergency, activate the system that Dr. Fowler talked about, that others have talked about, that is designed to save your life, so that we don't see, like we've seen recently, November's cardiac arrest numbers are about 20% higher than last November. We've had cases where, like I said, in July, it was almost double the pre-hospital cardiac arrests. Most of them called on scene because they were either unable to be resuscitated or didn't even have resuscitation initiated. Bethany, from your perspective as a full-time field provider, what are some of the things that you see when you're responding to these cases?
So here lately, we've had quite a bit of increase in the number of COVID calls, where we've seen an increased number of providers, both myself and other medics, that our primary impression has been that those patients have coronavirus. Like Matt was saying, we have had a number of patients that have declined transport just because of either fear of getting COVID in the hospital is a major concern, or concern about not having visitors as well. It's been a little bit better in more recent months, but particularly when the virus first came to the US, we were having almost, I would say, 7 out of 10 patients a day that were refusing coronavirus. Additionally, we've seen a lot of patients that are complaining more of symptoms related to depression or anxiety, whether about getting coronavirus itself or just because of the other social factors of not having friends and family around and such.
Yeah, so Matt, I just wanted to go back to some of what you were saying, just to make sure that that's clear for our participants. You're saying that the number of people who have had a heart arrest, basically that their heart has stopped at home before they even got to medical attention, that those numbers were much higher in July and even still in November than what you saw compared to last year?
That is absolutely correct. It peaked in July. July's cases of cardiac arrest in our system were 65% higher than they were the previous July. And we've seen that spike sort of consistently this year versus last year, starting in about April. So we know that when you compare, well, we theorize, Dr. Fowler, make sure that I don't misspeak here, but when you have data that shows people are waiting longer to call, they are, as Bethany said, they're declining transport to the hospital even when they're sick because of anxiety, we can theorize that a lot of these patients are just waiting too long to call, which is the whole Don't Die of Doubt initiative to make sure that people are calling when they have to. One of the things that we just told yesterday, and this will fascinate, I think, everybody on the panel and on the webinar, our percentage of patients who receive bystander CPR has fallen off of a cliff since April, and is at some of the lowest rates we've ever seen in the system. Currently, about 3.5% of the cardiac arrest patients are getting bystander CPR, and that's down from much higher rates pre-pandemic. So as we all know, in the chain of survival, that doesn't bode well for people surviving an out-of-hospital cardiac arrest.
Wow, that's really unfortunate. So it sounds like many more people essentially dying at home because they're waiting too long to get medical care or call 911. People who are having hours of chest pain instead of that hopefully single hour or even less of chest pain before they're calling 911. And then, as Dr. Schuessler said, you know, that time is so valuable in terms of having a good outcome. And so even for those people who get to the hospital, they may not do as well because they've waited so long. And then obviously just a lot of anxiety and stress about COVID itself, and concern about being exposed to that or potentially having that. That's really scary, honestly. Dr. Fowler, what are you seeing in terms of the impact of this anxiousness on patients in the emergency room?
Thank you, Nina. And Matt, thank you for those great comments. MedStar does a great job of data tracking and was able to validate our concern about the fact that more people are clearly dying at home or having cardiac arrests at home. We have got to somehow bridge this gap and let folks know that hospitals are a safe place to be. We had already seen in our ER the fact that they're, you know, as my old pappy used to say, human nature is what humans do, that there was a real nature of people to drive themselves to the hospital when they were having chest pain and shortness of breath. And we saw an enormous increase in that, in the tendency of people that they would not reach out through 911, where we have a very structured way to manage patients. They get their EKG, the EKG is transmitted, then the cath lab is standing by, and we're able to shorten the time of the ischemic event. Instead, folks, if they do seek help, sadly, Nina, unfortunately, often are driving themselves to the hospital. That is why this informational campaign of Don't Die of Doubt, seek the professional help that's been established in this wonderful North Texas region so that we can help you.
I think what you just said is so important. You know, it's not just that calling 911 gets you an ambulance, but I mean, that starts the medical care right then, as opposed to waiting to the time that you reach the hospital. And then even once you reach the hospital, there's a triage process in terms of trying to figure out how sick are you. Whereas if you come via EMS or our emergency medical services teams, they've already started all of those things for you so that the hospital is prepared to receive you, knowing what's happening already. And a lot of times have even started to get ready for your arrival before you're even there. And so truly calling 911 is a much better choice in the setting of an emergency than driving yourself to the hospital. Although clearly we prefer you to come to the hospital as opposed to staying home. But 911 is a much preferable option in that setting. Dr. Schuessler, what are you seeing in terms of the impact of COVID-19 on your patients? What are you hearing?
A little bit more to echo what they said, one of the technical aspects of opening an artery is actually easier when you come in earlier. So once again, coming in early. But I see people in the hospital, but I also see people in clinic. And one of the stories that I hear again and again and again is they feel so isolated. So especially some of my older patients, the only interaction with other human beings is unfortunately coming to see me and their other doctors in clinic. And I'm encouraged by the fact that, early on, back in April, it was a ghost town. No one would come in, they wouldn't come to the office, they wouldn't come to the hospital. We've gotten a whole lot better, not just in treating patients with COVID, but in preventing transmission. And it's a very safe place to be coming into the office. You're screened at the door, you are, put in a room by yourself. They are allowing family members to come in, and we have, knock wood, really not seen any transmission in those interactions. People have gotten COVID at home, and we've caught people coming in with COVID who have already been infected, but I've not known of any people who have been infected with COVID by having a visit with their physician. So they're very isolated. They are strange things. They can't understand people as well. Our interactions are different because everybody's wearing masks. I have a lot of people whose hearing is not the greatest, and it's amazing how much lip reading you're actually doing on a day-to-day basis. So communications are more difficult, but there's just a lot of fear and anxiety, not just living their lives, but going in and getting the care that they need. The one thing that I'm seeing again and again, even yesterday for my clinic, I had a number of patients cancel, and we're always asking, well, why did you cancel? Sometimes there's reasons. Most of it is concern for COVID. That again and again and again, this concern for COVID is why they're not coming in person. So we try to reassure them that coming in and seeing your doctor is very important. If you cancel your appointment, rescheduling, because we know there's going to be a huge backlog of patients once this clears out, is going to be more difficult. And then the other thing is we've come up with a lot of new options for interacting with your doctor in ways that we've never done before, including online like we're doing now. And it's amazing how quickly, especially the doctors, have figured out how to do online interaction. Some of my patients who I never thought would be able to send an email, 85-year-olds who are having online conversations with me, and I'm so proud of them for being able to do it. And I thought it would never work, but truthfully, there's a lot of things that we can communicate online and help talk through some of the problems that they have. So lots of different, not necessarily always medical, but lots of different changes that my patients are seeing.
Yeah, absolutely. Dr. Banks, do you have other comments there?
So, yeah, I actually totally echo what has been said. We still have a lot of people who are very hesitant to come to the emergency room. Thankfully, though, people are engaging our telehealth visits much more than they were previously, and we are learning how to treat people and take care of people virtually, which does do a lot for decongesting the medical system and does allow them some social interaction to kind of combat some of the depression that we're all seeing. So I'm happy for the fact that people are starting to engage in these telehealth visits with us, but we still are having a great proportion of people who are avoiding the emergency room in emergencies. So still some work to do in that area.
Yeah, I think there's some very important points that are raised there. That our offices and our hospitals are doing a great job of screening patients and mask wearing and all of those important preventive measures that were reviewed previously. but we do feel like it's safe to come in for those visits. But certainly if somebody is concerned that it's not, reach out to your doctor's offices and ask them about their telehealth opportunities, because most of us are doing virtual visits as well. And so, we don't want people to not seek care out of concern for COVID, even if it's a virtual visit, which most providers are offering now. That's still far preferable to just disappearing, which I think is a concern that many of us have that's going to happen to a reasonable subset of our patients. They're just going to kind of fall off of the list. I think that obviously there's a lot that we still don't know about COVID, but as we start talking about all of these things, I think we're starting to worry as well about the long-term health impacts. So not just the fact that people who are having urgent issues now aren't coming in, but that we may continue to see effects of this for the months and even years down the road. Some of those things that I was just alluding to, that certain patients may kind of disappear from healthcare because they kind of got lost to follow up in this initial part of things, things related to loss of jobs and therefore loss of healthcare coverage, in terms of the impact on food insecurity, a lot of these things. And I'll just kind of open this up to the panel in general. Can y'all all speak to what are your concerns going forward? What are you worried that you may see in the months and years down the road because of what we're seeing happen now?
Well, Nina, I'll start if you don't mind. There is a thing that we've learned for years called health maintenance. And it is so natural in the human mind to want things not to be there. I'll ignore my blood sugar. I'm sure it'll be okay. I'll ignore my hypertension. I'm sure it'll be okay. But the truth of fact, and all of us in medicine know that health maintenance is so critical. And so I would just say that I'm deeply concerned that we may see a delayed impact about the loss of health maintenance because of folks that have just elected to sort of not so much ignore, but postpone, shall we say, during this pandemic, the things that are essential to maintaining good health.
Absolutely. So, one of the things that I talk a lot about is, at least from a heart standpoint, those important preventive measures: blood pressure, diabetes, managing your blood sugar and your cholesterol, diet and exercise. And so many of those things are being sacrificed by a lot of people in the short term right now in terms of the health maintenance, seeing your regular doctor, being able to get exercise because of the gym, being able to get good food because of food insecurity and cost issues. And so there's a lot of potential for things not looking as rosy down the road for all of those reasons. Dr. Schuessler, do you have extra comments there?
Some of the
Jeff,
infrastructure
you're muted.
issues. There we go. The infrastructure I'm a little worried about. We're very fortunate in North Texas. We have very solid hospital system infrastructure. In some of the outlying communities, it was tenuous at best before COVID hit. And some of the smaller hospitals, I see reports all over the country where hospitals are closing down, shutting down. They were having trouble making ends meet before COVID hit. And it's been so devastating for them financially that the safety net in a lot of these smaller areas is disappearing. So that's one of my biggest concerns, how the lay of the land is going to look. It's going to be a healthcare desert in a lot of areas that were not before.
Dr. Banks?
Absolutely. You've all spoken to kind of the direct health effects that COVID will unravel a little bit. But speaking to the economic impact, health leads to and directly impacts wealth. And for a lot of people who are ill with COVID, some of them may have not had stable employment to begin with, and then they've had to quarantine and be on treatment and all of these things, and they've let health maintenance maybe go as well. Those particular individuals and also communities of individuals than they were pre-COVID. And so one of my concerns that will affect communities at large is just how the economic structure will be undermined in some communities and how that will directly impact their future health as well.
Yeah, absolutely. General economic impacts can have a big impact on overall health as well. Dr. Hernandez?
Yeah, and so another thing that I wanted to mention was that unfortunately it's also been so politicized that even though it shouldn't matter, health is important regardless of your political views, but it happened in an election year, and it's been so politicized, and it matters to the Hispanic communities who are directly impacted by other policies, and so I think the fact that it happened in an election year, and that mask wearing, the vaccine, and everything has been so politicized may have long-term impacts on how we approach health and even vaccines in the future. And so I think it's really going to be important that we take the politics out of our health, taking care of our health ourselves.
Absolutely. Any other comments? Okay, I'd like for everyone to just kind of give us a quick personal insight. So COVID-19 has certainly brought a lot of change for everyone. And I think that sometimes hearing about how much things have changed for all of us as individuals helps people in the community realize the broader impact of this. I mean, for me, it's been, a lot of little things. I used to wear regular clothes and now I wear scrubs so that I can wash them. I used to wear rings and now I don't because I wash my hands every 5 minutes, There are a lot of big things and small things that are impacting our day to day. I get my temperature checked lots of times, but if everyone could kind of speak to some of those, I think it kind of gives a clearer picture of how much this has become a part of our lives.
Nina, I'll start. Just following on to my comment about health maintenance, if there is a good news about the COVID thing, it's about the fact that if we will add COVID to our health maintenance duties as a person and as a patient, then we can help maintain health for ourselves and for the community. For example, Dr. Fauci, who I think should win a Nobel Prize for his amazing exposure and work for our country, has pointed out the fact that even after the COVID vaccine, we're going to need to wear masks because you may have some viral particles in your nose, even though you're now immune and you don't want to spread them. So I would just close my remarks by saying that why don't we all commit to adding masking and distancing as part of our health maintenance?
I think that's great. What are you all seeing in terms of your practice changes too, not just in terms of how it affects it for you, but what are y'all doing in terms of trying to keep your patients safe in the office and in the hospital?
So with MedStar currently, our ambulances, I would say, are probably cleaner than they ever have been. We've been very thorough with cleaning, ensuring that as providers, we're making sure we're wearing masks and providing one for the patients when they possibly present without one. Additionally, we've added filters, which we previously did not have in EMS when we're ventilating patients with BVM. We've also added video laryngoscopy, which is new to EMS here at MedStar, where we can keep a little bit more distance. It's a little bit safer as providers, but also if we prevent ourselves from getting COVID, and it prevents us from spreading it through the rest of the population as well. Additionally, for our patients that present maybe with lower acuity symptoms, maybe it's just a runny nose, a little bit of a cough, they're concerned that they might have COVID. Maybe the hospital isn't the place that they necessarily need to be. And so we've implemented what we call a COVID non-transport and referral policy, where their vital signs are normal, they don't have severe chest pain, they don't have any shortness of breath, everything's presenting as normal, no suspicion for clinical illness. that's severe, that our medical director allows us to give those patients a referral to follow up with a primary care physician or receive COVID testing outside of the hospital setting to allow other patients that maybe need those resources a little bit differently.
Absolutely.
So it's really interesting how I found a note on a patient from a few years ago where we were doing Ebola screening. I don't know if y'all remember that. And for a very brief period of time, everybody that came in was asked if they'd been to Sudan recently. I mean, of all of hundreds and thousands of people were screened. And I think I had one patient that actually took a trip to the Congo and everybody lost their mind. Comparing that to now, where we're actually seeing people where we're being much more particular about symptoms, we're checking everybody's temperature. We are personally being very protective as far as wearing masks and shields. And I've never seen so much hand washing in my life. Not that we weren't before, but it's to levels that we've never done before. I mean, the good news is that the medical system has really pivoted and been able to adapt to conditions that we never expected to have happen. None of us have ever seen anything quite like this in our careers. The unfortunate thing is all of the spinoff and some of the tragedy that we've seen. So we're doing a lot of things that have protected us. The physicians, you know, when this first started, we were very worried about us getting sick. We didn't know how exposed we were and if day-to-day interactions were going to cause problems. The good news is a lot of that has died down. People are much, not relaxed, but comfortable interacting with people who we know have COVID and taking care of them for things that are not COVID related, knowing that they are infectious. So care has continued. We've made huge strides. I think all of us are sort of waiting for the next 6 months to pan out, getting vaccinated and hoping that, I told a patient just yesterday, I hope when I see you again in a year, we'll all look back at this and say, gee, what a weird period of time we've just been through. So that is our desperate hope right now.
Nina, I would just add, I'm a full-time ER guy. I am yet to diagnose a case of influenza this year. I'm knocking on wood here. And so, go figure that routine, regular masking, throughout the community and of course in the medical environment is probably having some benefit on other diseases as well.
Yeah, absolutely. When there are questions, things like Dr. Hernandez mentioned earlier, does anybody have any suggestions on where to go for answers? I mean, we've also talked a lot about some of the misinformation and disinformation that's been out there. And so are there places you would suggest that patients turn to for accurate information when they have questions? Dr. Hernandez, maybe we'll start with you. You may have some good suggestions in terms of community resources.
Yeah, so the American Heart Association, and we actually recognized the American Heart Association recently because of the work that they've done in incorporating community health workers and making sure and educating the community. And so I think just finding those community-based organizations. I know for our organization, we've just had to get really creative in how we're reaching our communities. I've sat with some community health workers trying to teach them how to get on Zoom and with my phone showing my computer screen. And so we're just having to figure out how to reach our communities, whether it's social media, what are the trusted social media sites? Because again, there's so much misinformation on social media as well. And so we're currently working actually on a SEAL project with Tarrant County on really trying to understand what those concerns are in the community with the vaccine, with clinical trials, and encouraging people and identifying those barriers. And so, but again, figuring out how to do it creatively, working with other community-based organizations and making sure that we're sending the same message to our communities. And I think that's really key also, making sure that we're all on the same page, sharing that message. And just wanted to plug in another organization that's newly formed called La Alianza. It's a collaborative effort of organizations who serve the minority communities, Hispanic communities, and for the same reason, to have that unified message. And so one of the things that we hope to do is be a source for our community, a trusted source for our Latino community to get that information. And we do work with a lot of other community-based organizations to make sure that that's happening.
Absolutely. And I think that just kind of that general advice that we often give, even our students as they're learning about the internet, things that are .org, especially health organizations.org, are generally going to be good places to go. But we hope that everyone can kind of get the information they need. And we hope that today's panel gave you some of those answers to some of the questions that you may have, and that you can now be resources to others in your communities as well with some of that. As we're kind of nearing the end of our time, is there anything that we haven't covered that any of you feel is an important message, that kind of last, I need to get this out there kind of things that you want to share?
You're asking about good resources. It's always a good time to get a primary care physician if you don't already have one. I think that's having a relationship with somebody before there's a crisis, personally or pandemic-wise, is always good. So, never too late, never too early to get a primary care.
Absolutely.
Who is also a great resource, and really a personalized resource, because they know you, they have your medical records. So having that relationship, as Dr. Schuessler said, and then really using it, especially now with telemedicine. Many of those primary care physicians are literally a phone call away. So that could be one of the most reliable resources when patients have questions to go to, because the physician community has been phenomenal in getting information for themselves and also for their patients, as opposed to the patient reading it somewhere on the internet.
Matt, you've had a very novel outreach through MedStar into your community by way of your community paramedics. Is that also an option possibly?
Absolutely it is, especially, we're rolling out a new program that's partnering with the hospitals for things like not only the COVID vaccines and the things that we're going to be doing with the vaccines, and even have talks with JPS and THR about doing some of the monoclonal antibody infusions using our AMBUS, for example, Dr. Fowler, where you could put 3, 4, 5 patients at a time to do that. But also, again, when patients are enrolled in the community paramedics program, providing them with information about the coronavirus, but more importantly, how to connect with those primary care resources, whether it's an FQHC is going to be their patient-centered medical home, or getting them connected with a PCP.
That's really great. One last question. Of course, we're in the midst of our holiday season, Christmas approaching. What is the message that you would want to put out there for our participants to hopefully help carry to the rest of their communities, in terms of what are your recommendations and your thoughts for this next month or so?
Well, it's so important. I'll start out. It's so important to enjoy the holidays and the blessings that come with being with family and friends. I think this year that we have to roll our blessings into a little bit of a different place, which is to say that part of the blessings we're sharing is the fact that we're going to keep confidence amongst our family and our friends, that we're going to get through this together by love and friendship, but nonetheless keeping our distance, wearing our masks, washing our hands, and realizing the fact that this next year is going to be a whole lot better for all of us.
Amen.
Well said. So with that, I think that concludes our panel discussion. I would like to thank all of our panelists for participating. I think you've all provided some very useful information and some great insights into COVID-19 and its effects on heart health and the health of our communities in general. So I really appreciate all of you taking the time to be with us today. And to our attendees, thank you so much for joining and making this a priority. And we hope that you can take this message and share it in your communities as well. And with that, I will turn it back over to Jenny to see if there are any other questions or comments. Thank you.
Thank you, Dr. Esrani. And thank you, echo Dr. Esrani's comments. Thank you to all of our panelists. I know I just learned so very much and grateful for each of your times today and for the information that you shared. It was truly incredible. We are appreciative for all of you, and as Dr. Esrani said, grateful to all of those of you joining us and attending today's program, and for your interaction in the chat. We've been monitoring it, and for those questions that didn't get answered, we'll be working to follow up with you to make sure that you have those answers and that information to share with the people that you see every day. I wanted to also share that the American Heart Association has been working to put together infographics and one-pagers around the Don't Die of Doubt message that we would love to get to you, whether you are putting it in your offices, sharing it with your family members over Zoom, or however you're getting together with people today. We truly want to get this message out. I think it was just incredibly important for us to hear what each of our panelists are seeing on a day-to-day basis, knowing that there is still a hesitation to call 911, and we want to make sure that those that need care the most are able to receive it in a timely manner so that we can have really wonderful health outcomes in our communities. So please feel free to reach out to us, to come back to our website, our emails, and I'll make sure that that is in the chat as well. But please reach out. We'd love to share the information to make sure that you have it and are able to use it. So again, thank you to everyone for joining us. Thank you to our panelists. We appreciate your time today and hope that you are able to leave here with some great information to share across North Texas as we work to get this important message out. And I also would be remiss not to thank the WWW Caruth Foundation at the Communities Foundation of North Texas for making this possible for our work here in North Texas around Don't Die of Doubt. Thank you all. Have a great rest of your morning, and we will be in touch soon.